Good evening, ladies and gentlemen. Uh, I first of all thank Dr. Murlidhar sir for continuing this excellent academic feast for the people who wish to learn or share their experience of echocardiography. 15 years is not a small time. It's really commendable to continue this exercise for 15 years and that too improving year by year. So this year, the topic given to me is the cardiac cannulation and minimal invasive cardiac surgery and how the TE can be helpful to that. Perioperative TE has been proven by many papers, and this is the one of the good paper published in 2012, which says that the TE works as eye to the surgical procedure. It helps us guide for different procedures. It can alert us for any possible complications, and it gives a monitoring tool also that what is happening inside. Uh, when we talk about the surgical cannulation procedures, certain things come into our mind, like the surgeons do aortic cannulation for cardiac surgery. It may be directly into the ascending aorta, femoral artery, or axillary artery. They need to cannulate sometimes the coronary sinus for retrograde cardioplegia, or the aorta for the antegrade cardioplegia. And definitely there are venous cannulations of superior vena cava, inferior vena cava, bicaval cannulation to withdraw the blood from the heart. And all these cannulations need a special technique. And sometimes the surgeons look at us and they ask us whether they are doing it correctly or not. Apart from the surgical cannulations, we need to do other cannulations like central line placement, as done by the anesthesiologist, the interjugular artery cannulation, pulmonary artery cannulation. And apart from that, sometimes in cardiac cath lab also, different procedures are done like balloon mitral valvotomy, balloon aortic valvotomy, pacemaker lead placement, or pericardial tap. For all these things, the echo is expected to give them an answer and give them a comfortable atmosphere so that the procedure goes uncomplicated. Apart from these routine cannulations, there are certain advanced techniques have been in practice now, like placement of ECMO cannulas, LVAD placement, IBC filters for pulmonary embolism, device closures of ASD, VSD, PDAs. TAVI is very popular nowadays, the mitral clips, percutaneous mitral valve replacement. All these procedures need proper device placement in the different chambers of the heart. And to have a good result, we need something or somebody to guide us that the procedure is successful. So before going to the detail about each and every cannulation, I must say that we must have a comprehensive echo examinations. We must try to get as much as possible out of those 24 or 27 views of comprehensive TE examination. Look for any congenital acquired anomalies. Look for any valvular or dysfunction or ventricular functions are proper or not. And must before doing any TE examination, we must be very careful that there is no contraindication for transesophageal echo in that particular patient. Coming to the aortic cannulation. Aortic cannulation is done in most of the cardiac surgical procedures, where open heart or even in other cases also. The TE gives an advantage that we can see the guide wire, the descending aorta, as the most of the surgeons nowadays put cannula over the guide wire. TE helps us to evaluate different aortic atheromas. It rules out the dissection or rupture if there is any complications, but there are certain limitations also to the TE. For example, there is peripheral cannulation is done many times for dissection or aneurysm cases. That is from the femoral or axillary artery. But these peripheral sites are away from the range of transesophageal echo because the transesophageal echo can see within the thorax or part of cardiac structures below the diaphragm also, but beyond that, the TE is not very helpful. And there are certain areas which are called the blind spots in the aorta where the TE is unable to find out the take the pictures. So let us see an example of aortic cannulation. If you see in this picture, there is a guide wire placed in the aorta. This is in the long axis, and you can see here in the short axis. And this guide wire, being a metallic structure, can be easily seen in the lumen of the aorta. And once you find the guide wire in the aorta, aortic lumen free, you are sure that the surgeon is cannulating the aortic lumen, and they can slide the cannula over the guide wire. Same way, if you see in this picture also, there is a guide wire seen inside the lumen there is no dissection, and similarly in the short axis. So we must always try to look the things in the long axis and short axis. Now, apart from the central cannulation, in this picture, if you see, there is a cannulation from the axillary artery. So even if for the axillary artery cannulation, we should be able to see, uh, this is again a peripheral cannulation from the axillary artery, and we can see the uh, arterial cannula into the coming from the axillary artery to the aorta, arch of aorta. And here again, we should be able to see the guide wire, and then the cannula slided over the guide wire. When we go for the central cannulation, sometimes if it is little distal or more towards the arch, we are able to see the cannulation in the aorta, and the flows from the cardiopulmonary bypass pump can be seen flowing towards the aorta clearly. Thus, we can rule out any dissection or any other complications because of cannulation. So once the surgeon has done the cannulation, we must do an echo check. So in entire presentation, whatever we do, I'm just trying to explain and going very practical that once the surgeon has done it, you must go for an echo check. So in echo check, what you do, you rule out any dissection, you rule out any perforation, you check for direction of flow, especially in the axillary cannulation, because sometimes the axillary cannula might go towards the common carotid artery, or innominated artery on the left side, and the direction of flow may go towards the upper part of, away from the heart towards the cerebral circulation. Then we must be able to look for the length of cannula inside the aorta. If there is X-ray cannulation, it should be well inside the central aorta or arch of aorta, and we must look for the free flow of blood. Next comes the coronary sinus cannulation. Coronary sinus cannulation we do many times because there are some coronary patients we need to give the retrograde cardioplegia, or there is aortic regurgitation. Again, we have to give the retrograde cardioplegia, or there is minimal invasive cardiac surgery. The surgeons sometimes prefer to give the retrograde cardioplegia rather than cannulating the proximal aorta. So coronary sinus cannulation under T guidance is quite easy. It gives because the surgeon is going blindly towards the coronary sinus, and the T can guide his coronary sinus cannula towards the opening, and then we can confirm it is properly placed or not. Uh, we can look if we in the routine checkup, if routine T examination we find there is a aortic wall is incompetent, then we can suggest the surgeon that we should preferably go for retrograde cardioplegia. Uh, we can assess the main coronary vessels. The retrograde cardioplegia going from the coronary sinus will ultimately come out through the coronary ostia. And sometime in the cath lab also, when the cardiologists are placing the biventricular pacing, then they put one lead into the coronary sinus, and echo can guide them whether their guide wire is going properly into the coronary sinus or not. So these are the few examples. This is coronary sinus view. That is the lower esophageal view with a retroflexion of probe with 0-degree angle. This is where the coronary sinus is seen, and this is where you can see the cannula placed in the coronary sinus. You can see the length of cannula in the coronary sinus as well, how much deep it is gone into the sinus. Then antegrade also, you can check whether the blood is flowing into the coronary ostia or not, or there is incompetent wall which is flowing the blood towards the LV. And once it is done, we can check the flow of antegrade cardioplegia coming from the coronary sinus towards the right atrium. So echo check, whenever we do antegrade cardioplegia, we must check the drainage of cardioplegia solution to coronary sinus. If cannulation is proper and free of complications, is there any LV distension due to aortic regurgitation? We can check the position of coronary sinus cannula. We can look for, if it is retrograde cardioplegia, we must look for drainage into the aortic root. And after the surgery, we must make sure that there is no dissection of the coronary sinus. The right heart, the LSVC, these are the things which can hamper our procedure. And let us go quickly one by one. Bicaval cannulation, we must look into the uh, uh, bicaval view, midesophageal bicaval view, the superior vena cava, inferior vena cava, and the left atrium and septum and the right atrium. And we can see the guide wire and we can see the cannula gliding over the guide wire. This is the IVC cannulation, and you can see the cannula which is sliding over the infradiaphragmatic part of the IVC. These are pulmonary veins. We must make sure that the pulmonary veins are not blocked. We put a Doppler and see if the pulmonary vein Doppler flow is correct or not. It means the cannula is not blocking the pulmonary veins. IVC cannula maybe from the femoral vein side also. We can see the guide wire and we can see the cannula. This is the guide wire coming from the IVC to the right atrium, and the cannula can be seen gliding over it. If the cannula is too much inside the right atrium, we can suggest the surgeon to withdraw so that it remains within the inferior vena cava, and he can put a clamp on the IVC for a air-free circulation. So echo check is we should see for any obstruction of the hepatic vein. There are 10% chances that right hepatic vein may be cannulated. We must look for that. We should look for cannula in the coronary sinus, a cannula in the hepatic vein. We must look for kinking of cannula and position of cannula. Then superior vena cava, again the Seldinger technique is used. We must keep at least 2 centimeters above the SVC RA junction so that surgeon can put a snugger on the SVC RA junction. Again, you can see this is the superior vena cava. So from here, the guide wire is coming. And this guide wire, if you see, as the guide wire comes into the right atrium, the cannula is slided over the guide wire. But this cannula is too much inside the right atrium, so we withdraw it to the extent that it remains above the SVC RA junction. And at least 1.5 centimeter length is required so that it can drain properly the upper extremity. Again, the same thing, how we check the tip of the cannula and how much above it should be from the SVC RA junction. Then coming to the pulmonary artery catheterization, the RV inflow outflow view is a good view where we can see the tricuspid wall, from tricuspid wall to the pulmonary artery and pulmonary wall, and we can glide our Swan-Ganz catheter as we see in the echocardiography on the screen. This is how the cannula passes from tricuspid wall, right ventricle to pulmonary artery and to the different pulmonary artery later on. Again, for the central venous cannulation, we should keep the tip of our central triple lumen or four lumen above the SVC RA junction. As we said, for the cannulation, the same thing is followed here. We must look for the guide wire and then tip of the cannula. Ibp placement is a very important thing because we need to keep the Ibp below the level of the left subclavian artery. And if you see, this is how the IVP looks inside the aorta, the pulsating balloon. And we must look for the left subclavian artery. Once we are looking for the left subclavian artery and we can look for the flow in that, we must not be able to see the cannula. This is a rare picture of where we have put a patient had a complete block of descending abdominal aorta, and we put a IBP from the axillary artery. So this is aortic short axis view. This is pulmonary artery, and this is a pulmonary artery. And this is aortic short axis view, and if you see, you will find a IBP cannula in the pulmonary artery, in the arch of aorta. So we have put the IBP from the axillary artery to the arch of aorta because patient required it because of the coronary reasons, but the descending aorta was blocked. Sometimes we need E for ASD device closures. Maybe you can see how we can see the function needle tenting the intraatrial septum. After that, sometime for how it crosses the mitral wall, and for the LVAD placement also, the echo helps to guide the surgeon about the proper placement and the wall opening. Nowadays, transcatheter mitral wall replacement are practiced, so echo is must for them. Now, coming briefly about the minimal invasive cardiac surgery. Minimal invasive cardiac surgery is now very much in routine because we need a smaller size of incision, good healing, less bleeding, and all those things. But certain things we must tell our surgeon which prevent the minimal invasive cardiac surgery. I mean, because if they are present, the MICS is not possible. These are enumerated here. So let's quickly go one by one. So IVC cannulation, as I explained earlier, IVC cannulation is very much done under PE guidance because two-stage cannula, you can check whether the guide wiring from IVC to RA to SVC is going properly or not. Same way, placement of cannula, IVC cannula, SVC cannula, one must look for any obstruction to the placement of cannulas if it's put directly from the RA side. This is eustachian wall which can hamper the placement of cannula. Same way, if there is presence of LSVC, as you can see in the yellow circle, the LSVC presence will not allow I mean, blood field circular, uh, blood-free field for the surgeon. So they need to put an extra cannula in the LSVC. Or if there is a dilated coronary sinus, then the coronary sinus cannula placement may be difficult. We must rule out ASDs because sometimes it's incidental finding that there is ASD, and if you're operating on mitral valve, then it won't be possible to go for the single cannula, two-stage cannula. There may be sinus venosus type of ASD one must rule out. Again, we must rule out atheromas, mobile atheromas or thick atheromas present in the patient. Then sometimes there is PAPVC. In this picture, you can see the right upper pulmonary vein is opening the SPC. So all these things should be ruled out. And if there is aortic regurgitation, definitely we must inform the surgeon that this patient has got AR and the crosslamp may be problematic. And so to conclude, perioperative PE is a diagnostic as well as a monitoring tool. A basic comprehensive echocardiography is must before a cannulation procedure is performed. A comprehensive PE examination is must that it provides a baseline information and rules out surprises during the surgery. Echocardiography makes cardiac cannulation a safe procedure, which is under vision and the vision can be on the monitor of the screen of the echo machine. And the echocardiography is a guide to surgeon for cardiac cannulation. It saves the operatory time and thus avoids so many complications. So the final answer is P important for cardiac cannulation and MICS, minimally invasive surgeries? The answer is yes. And I would say it is essential for all these procedures because it makes the life of surgeon comfortable and it avoids a lot of complications. So with this, I must thank you all for your patience and wish you good luck. And I'll be taking the answers as decided by moderators. Thanks again for the patient listening. Enjoy the next presentation. Thank you.